In this study called the InformCLL registry, this is the real-world outcomes with first-line Ibrutinib versus first-line chemoimmunotherapy in patients with CLL, SLL, and this is from the InformCLL registry, which is one of the largest disease registry of patients with CLL in the US and provides a valuable opportunity to explore real-world treatment practices and outcomes. Ibrutinib and chemoimmunotherapy were the most frequently administered first-line regimens, so that makes it easier to compare. And we report the real-world outcomes of this on the study. The patients with CLL initiating therapy were enrolled in this registry from October 2015 to June 2019, and these patients were followed for a minimum of 2 years. Additional, eligibility criteria will be available on the ASH abstract. The outcome measures include the current analysis were time to next treatment and safety, and to allow for comparative analysis of TTNT between the first-line Ibrutinib and CIT cohorts, inverse probability of treatment weighting using propensity scores was performed, and this allowed for adjustment of confounding by balancing the baseline patient characteristics between the two treated cohorts. And these were then compared using Cox regression analysis in the weighted cohorts. So this, again, is not a randomized comparison. So, we use, these propensity score matching to sort of match the best we can. And then safety was assessed based on overall incidence of adverse events, as well as by exposure-adjusted incidence rates of AEs in the first-line Ibrutinib and the chemoimmunotherapy cohorts. So 854 patients were treated in the first-line setting, and the first-line cohort included 383 patients treated with Ibrutinib and 363 patients treated with chemoimmunotherapy, so a substantial number of patients. And the patients treated with Ibrutinib tended to be older than the patients with chemoimmunotherapy. And patients treated with Ibrutinib had longer time from diagnosis to treatment and were more likely to have history of other malignancies. And among the subset of tested patients were more likely to have high-risk genomic features such as deletion 17p or p53 mutation. With a median follow-up of about 32 months in the overall first-line cohort, the time to next therapy was not reached. In the IPTW adjusted analysis in the first-line Ibrutinib and chemotherapy cohorts, median time to next treatment was not reached for Ibrutinib and was 56.5 months for chemoimmunotherapy. And in the model using IPTW adjusted analysis, time to next therapy was improved with Ibrutinib relative to chemoimmunotherapy with a Cox proportional hazard ratio of 0.74. The duration of index treatment was also longer with first-line Ibrutinib, with a median duration of 24 months with Ibrutinib and 4.7 months with chemoimmunotherapy. And in terms of serious adverse events, they occurred 38% of patients with Ibrutinib and 23% of patients with chemoimmunotherapy over the course of treatment. And the adverse events leading to discontinuation occurred in about a third of patients with Ibrutinib and 17% of patients with chemoimmunotherapy. And given the difference in duration of treatment with first-line Ibrutinib and chemoimmunotherapy, adverse events were also evaluated using exposure-adjusted incidence rates. So we know that the exposure to Ibrutinib was longer, so we are adjusting for that. So when we adjust for that, the overall rates of serious adverse events and overall rates of adverse events leading to discontinuation were actually lower with Ibrutinib than with chemoimmunotherapy. And exposure-adjusted rates for serious AEs as well as AEs leading to discontinuation were also lower with Ibrutinib than chemoimmunotherapy, with the exception of hypertension and cardiac disorders. Exposure-adjusted rate for adverse events resulting in death, which is a subset of serious AEs, was also lower with Ibrutinib than with chemoimmunotherapy. So we have to understand the limitations of this kind of an analysis. As I described, this is not a randomized clinical trial. This is real-world data. And an important limitation is that the time to next therapy data for Ibrutinib versus CIT was based on modeling using propensity scores and weighting methods in order to adjust for confounding variables, right? So these do allow for comparative analysis between non-randomized treatment cohorts, but obviously it's not as good as a randomized clinical trial. As such, the time to next therapy data from this analysis, therefore, should not be directly compared with the results of other real-world studies or clinical studies. But to conclude, the current analysis from this large InformCLL registry shows that this IPTW-adjusted analysis, first-line Ibrutinib, was associated with longer time to next therapy than chemoimmunotherapy in a real-world setting, with sustained benefits up to 4 years following with follow-up on this registry. And when adjusted for differences in duration of treatment exposure, first-line Ibrutinib was associated with lower rates of serious adverse events and lower rates of AEs leading to discontinuation overall than chemoimmunotherapy. So that's what we can conclude from this large registry study. Thank you.